Good morning. So this morning I'd like to talk about lipids for the preterm infant. Sort of some controversies and questions. I'm not sure I have a bunch of answers just yet, but we can discuss that in the question and answer period. You've seen some introductory slides already about lipids in general. You'll see that I'll speak mostly about fatty acids and what we know about each of those components. But just to start with a brief overview, preterm infants have very limited endogenous lipid stores. It's an essential component of PN, as you've heard this past day. It does serve as a source of linoleic acid, an important precursor. But as you listen to the lecture, we're going to talk about, does the baby utilize that precursor very well, and what happens to linoleic acid levels during the preterm period in receiving lipid emulsions. Lipid emulsions are necessary to prevent essential fatty acid deficiency, but this could be done at a relatively low dose at 0.5 to 1 grams per kilo per day. We also heard how it meets high energy needs as a high caloric source at 9 kilocalories per gram. And it's an important source of an alternative fuel for gluconeogenesis, which may allow us to reduce the total glucose load we get and the risk of hyperglycemia. So I think in the Q&A period, we can also talk about the different styles and the advancement of starting lipids. That still varies across the country. You'll hear some differences even among our group here. We still start at 1 and advance incrementally until we're at 3.5 grams per kilo per day by day of life 3. We've shifted to start earlier, but I think even in our unit we can perhaps be more aggressive. Also, we can talk about the importance of monitoring triglyceride levels, whether that's useful or not. In our unit we do, and I'll talk a little bit about that historically. And you've also heard that a 20% preparation is recommended. I don't think we use 10% anymore. Just a couple of quick slides to remind you of the importance of lipids as an alternative fuel source. Here's a study. What they did here, they would have infants starting at 10.8 mg per kilo per minute. Then they would drop down to 6.1 and then 3.1, while remaining constant the amount of amino acid delivery and the amount of lipid delivery. Then they monitored glucose levels throughout that transition. And you can see that despite ramping down on the total glucose administration, the systemic glucose levels were maintained nicely. Another study to reflect the importance of lipid and gluconeogenesis. Here we have infants that were on glucose, amino acids, and interlipid. When they took away the intralipid, you saw a drop in the gluconeogenesis. Whereas if you withdrew the trophamine, the amino acid, you did not see that same fall in total gluconeogenesis. So lipids and the delivery of lipids and fats remain very important in that glucohomeostasis. Even a short delay can cause essential fatty acid deficiency. We heard that it consists of a dermatitis, alopecia, thrombocytopenia, susceptibility to infection, and failure to thrive. They also increase free radical formation and susceptibility, and as I mentioned, can be prevented with a small dose, daily dose. And then also less reliant on the glucose calories, as I just reviewed. There's been many potential consequences of lipid delivery that have been mentioned in the literature. I'll tell you, most of this has been theoretical or animal studies or even some autopsy studies of premature infants who had expired. But even those may be a bit flawed as well. So I mention them because I think it's important to be cognizant of them, but I don't necessarily drive my lipid management around these issues. The potential risk of sepsis and the association of lipid emulsion with coag-negative staph, displacement of bilirubin from albumin, pulmonary, whether it's deposition of fat globules in the capillaries, the macrophages, and the arterial lining cells, increased pulmonary vascular resistance, Are you increasing the risk or exacerbation of chronic lung disease or the exacerbation of persistent pulmonary hypertension, coagulopathy and liver failure, and the effect on leukocyte function? So other considerations that we could talk about, practices and differences, is carnitine. You heard that mentioned yesterday, as it's thought to be important to bring the fatty acid across into the mitochondrial inner membrane to assist in fatty acid oxidation. We do use carnitine. We do it selectively, however. We will start carnitine in infants less than 1,000 grams, or if our low birth weight infants are on PN for an extended period of time. This is what we do when we do measure the hypertriglyceridemia or triglyceride levels, is that we try to maintain less than 200 at a minimum. So if we have a triglyceride level between 150 and 200, we will add the levocarnitine, but we would hold our advancement of the total lipids. So if we happen to check check triglycerides at day 4 because we didn't start lipids till day 2. We've shifted that up a little bit. But then if we see that our triglyceride level is above 150, we would hold at that advancement level for that day. If it's over 200, we discontinue the lipids. We add the levocarnitine when we resume fat at a lower infusion rate once our subsequent triglyceride level is less than 150. Has there been a lot of solid evidence that allowing your baby during that period of intralipid and lipid emulsions to have a high triglyceride level is a problem later in life? I think the best evidence or suggestion I have seen recently as preparing for this talk is there was and I guess I didn't bring it over into this talk. I'll maybe try to update you later today or tomorrow and find that reference. But it came from the cardiology group looking at preterm infants and triglyceride levels when they were followed, and then as young adults and as they were older, having more issues with cardiovascular disease. So this is historically, I just wanted to tell you this story quickly about why we do measure triglycerides or why we continue to measure triglycerides. But I think it's also a nice story of just multidisciplinary care back into the units, how everybody sort of plays an important role. So we already had in our policy that we would check triglyceride levels, and then there was a period of time, all of a sudden, we noticed a big change in the amount of elevated triglyceride levels, and we weren't sure what exactly was going on. Our practices weren't necessarily different. So I spoke to the pharmacist, and and then he spoke to one of his pharmacists and PhD, his name is David Driscoll, and he was on the FDA committee about sort of standardizing what the standards had to be met for lipid emulsions. And when we told him that all of a sudden our babies were having these elevated triglyceride levels, I'll show you the incidences, but we went from like 6% to over 20%, over a quarter of our babies. And he said when we came to him, he couldn't believe it because at that time he was in discussions with Baxter because they had changed the way they were manufacturing their lipids. And he was noticing in the lab that they had much more instability, much more percent in the amount of large fat globules that were in solution. So to assist sort of everybody, but also him to get that information back so that that change could be made, we performed this retrospective study. We actually, in fact, also had a prospective clinical study going on, but Baxter changed their product before we were finished, which was good news. Bad news for my study, but good news for the babies. So this is that story. So we looked at so when you have a fat emulsion, you'll have particles of all different sizes. But the standard is such that no particles, or you should have less than 5% of particles greater than 5 micrometers there. And so what we saw is that, and what he was seeing in the lab is that there were a greater density of those high molecules. So we did a retrospective review where we had the period where they were manufacturing in glass, which seemed to have no problem, June 2nd, December 31st, 2003, to a plastic period, the same months in 2004. We looked at triglyceride levels. The day of life, we checked that triglyceride level, and the incidence defined as elevated of greater than 150. So what we found is that we did see that triglyceride levels seem to be related to birth weight, But even though in the plastic period our babies were a little older and a little bit bigger, they were much more likely to have had a high triglyceride level. So traditionally, you would have expected it the other way around. The lower your birth weight, the lower your gestational age, the higher incidence of your triglyceride level. So after correcting for other potential confounders, that new product remained elevated. You had almost a 6-fold increase in the odds of triglyceridemia if you were receiving lipid emulsions during our plastic period than before. So then the final good news. This is a letter we received. Thank you for your inquiry regarding globule size. During this course, they made ongoing improvements and now are manufacturing a product with PFAT5 less than 0.05%. So there can be changes in products, changes in instability. We know that triglyceride levels might be related to low birth weight and gestational age, and so we do continue to monitor triglyceride levels. All right. So I want to shift gears a little bit and go back to the focus here with nutrition, especially lipids, and how is that as an potential immunonutrient source. So you recall yesterday I brought up this model because I was explaining how intestinal injury, or the way we enterally provide substrates, might actually continue to propagate a systemic inflammatory response. And that intestinal injury seems to cluster with other disorders that we see in the NICU. So really bringing back the time frame, which you've heard over and over, to this early period, this early postnatal period where you're modulating those risks. And then I also showed you this, where yesterday we talked about nutritional practices and other medical practices altering that postnatal intestinal adaptation, leading to immunomodulation that may not be to the benefit of the infant, the systemic inflammatory response, risk to local and systemic disease. Today, with the lipid discussion, I want to talk about that as an immunonutrient, potential immunomodulation, and how that may help with this process. I think Dr. Bell summarized this nicely, and I will just concentrate on the long-chain fatty acids. So fatty acid metabolism, very important as an energy source for tissue growth, and perhaps most importantly, two things: neurodevelopment. So it's really the incorporation of fatty acids, and these long fatty acids these long fatty acids into cell membranes. And the structure of these long-chain fatty acids allow this fluidity of these cell membranes, so they can do their function and signal their pathways and allow them to interact with each other. If you have unsaturated or you don't have those, enough of those polyunsaturated fatty acids, your membranes become less fluid, a little bit more rigid, unable to do its job. It's also very important in regulating systemic inflammation. But it's also both. It can produce pro-inflammatory cytokines and mediators, prostaglandins and leukotrienes, but can also be an important source of anti-inflammatory markers. So another theme that, even though I'll speak a lot of DHA, I want to keep coming back to this, and if I forget, remember, it's really about the balance of these fatty acids. It's not just one. They interact with each other, they compete for enzymes, they compete for membrane sites, and so it's important to really be considerate of all the different fatty acids, not just DHA. So moving forward, I'll speak about fatty acids, the role on intestinal development, how common nutritional practices influence what we see in our preterm infants, and discuss some potential strategies moving forward. It was also mentioned this morning how the fatty acids are transferred across the placenta. So maternal sources are important. There's active transporters that are put in place. And here is probably a good example when you're looking at circulating phospholipids. It's really this last part of pregnancy, 28, 30 weeks and beyond, where you see what they call in the literature biomagnification of these fatty acids. Another representation, maternal stores and levels, how the placenta has a large increase in these phospholipids to deliver them biomagnification across the placenta to the baby, especially within fat stores and in the brain. So teleologically, it also makes sense that it's during that last part of the pregnancy where you want to just rapidly grow your brain and also continue your retinal development. So now I want to talk about how I started to look at this about 1.5 years ago. So these are general incidences of any ROP. You probably see this about 40%. This is any, even mild. Long-term cognitive impairment, you've seen from the literature, 25, 30, 35%. Chronic lung disease varying. In our unit, it's about 45%. Late onset sepsis, 20%. And necrotizing enterocolitis, 5%. In the literature, 5 to 10%. In our unit, closer to 5. So what is common? So what's possibly common is these are all the brain and the eye, neurodevelopment, and the other factors being very excessive or chronic inflammation. So that's the other theme I think you'll hear from me, is that I really think about nutrition and immunonutrients in responding to this early pro-inflammatory environment of the baby, and that it's important to really think about that. So we just discussed this. So in utero, that last trimester, again, for simplicity, I'll concentrate on DHA, but we'll talk about the balance of all of these. Biomagnification across. But we all know that our babies are born early and they miss that last trimester of DHA delivery, at least in the United States. And I would love to hear your opinions. And here in Europe and the changes, I think you're actually a little bit more progressive than we are in the different lipid emulsions that we use. But in the United States, we use intralipid. The Baxter product, primarily omega-6, doesn't have any DHA, or very little DHA. So essentially, we remove them from the source, and we don't even think about replacing them adequately. So my questions were, what happens to these levels in the babies? And if they're low, do they cause disease? Does it matter? We can give several examples where there are postnatal adaptations that are important to be made. So maybe replicating or changing, maybe it doesn't have a biological importance. How I answered this question about 2 years ago, started a biorepository where I collected all samples, nutritional, breast milk, blood, fecal samples, linked it to clinical information, and this has allowed me to look at fatty acid metabolism, fatty acid levels, absorptions, and other things. To date, we have about 415 kids in that repository, and this study was looking at my first full year of infants less than 30 weeks, so it was about 88 infants. So let me show you and walk you through this slide. This is what we found for median DHA levels in our babies. So along the x-axis, I measured at birth, after the first week, second week, third week, and fourth week, measured fatty acids in whole blood, and it's represented as mole percent. So of that percent of your fatty acid pool, what percent comprised of DHA or the other fatty acids we'll talk about? So mole percent is on the y-axis. For a quick comparison, because I didn't know where they would have started, I had 10 full-term infants who contributed birth levels to their fatty acid. So at birth, in a term infant, their DHA level was 7.5 mole percent. For my total cohort, the median DHA level for the preterm infant was about 7 mole percent. So when taken from the environment, they were being exposed to a relatively high fatty acid concentration. Theoretically, if they remained in utero, they should be during that latter gestation, so during our period of 24 to 37 weeks, perhaps should be exposed to DHA levels in about 7.5 mole percent. Now, the other thing I want is these mole percents, and I was learning as well, these are actually extraordinarily high mole percent levels, which I think also indicate the importance of fatty acid delivery and why these whole systems are even in place for the placenta transfer. So a colleague I'm working with, he's in cystic fibrosis and looks at fatty acid metabolism in cystic fibrosis. When he first looked at these numbers, he was like, this is unbelievable. Even, he said, if you pour in 3-4 grams of DHA in an adult, you may go from about 1.5 mole percent to about 3 mole percent. So these numbers are extraordinary, and I think reflects, again, the importance of these polyunsaturated fatty acids. So what I found that by the first week, these levels dramatically decreased. Again, probably not that surprising given that we're not replacing it postnatally. And they remain, and they sort of leveled out. So instead of 7 mole percent, they were about 3.8 mole percent, and they stayed there. So accruing a deficit very early after being born. What about the other two kind of fatty acids? Well, let's take the top one. I know it's a busy slide, but let's take the linoleic acid first. Again, the preterm and the term infant at birth start about the same, but linoleic acid almost triples in its content. If you think again about what we give in the intralipid, not surprising. We pour in linoleic acid, and they're accumulating it. They're not necessarily able to process that down to the downstream fatty acids. And we could talk about those theories. There's been discussions about enzymes and whether the ability of the preterm infant to utilize precursors in a manner to be able to produce the DHA or other downstream fatty acids. There may be some competing risks of the level of illness that we'll have to try to sort out as well. And then arachidonic acid looks a bit like DHA, where together they start higher, it falls by the first week, and then it plateaus out. So changes in fatty acids that are essentially by the first week completely opposite in ratios and levels that they were otherwise being exposed to if they had remained in utero. So then the question, is this important? So some of these deficits have been described before. And I think this may have been the first to actually show, well, you know what? Not only long-term neurodevelopmental consequences may result because of this, but even short-term morbidities. And these morbidities also being important in determining neurodevelopmental outcome in the preterm infant. So we looked at chronic lung disease. Here you see the time course of the DHA levels of infants who did not get chronic lung disease compared to the infants who did get chronic lung disease. You see a substantial difference of where their DHA levels and the contribution of that. Here is the modeling I did because I felt, of course, it was important to adjust for what I could. A lot of people said, well, maybe it's just because they're really sick. Well, we modeled for gestational age, gender, growth restriction, and severity of illness, and the total fat intake that they were receiving. And we saw that these relationships with the fatty acids persisted. So this is how you'll read it. DHA, for every 1 mole percent decrease in your DHA, you were at 2.5-fold higher risk of developing chronic lung disease. The ratio being important. So this is linoleic acid, omega-6 to DHA, and omega-3. That ratio, every change, unit change in that ratio, 8.6-fold higher in developing chronic lung disease. Confidence intervals are wide with this number of 88 infants. Late onset sepsis, and this is where I think it's critical, and we'll talk about the different emulsions, but it's not just a DHA story. Linoleic acid, we'll talk about, but the arachidonic acid, every mole decrease, 1.4-fold higher in developing chronic lung disease, and the ratio of LA to DHA still being important, almost a 5-fold increase in the risk of sepsis. So I had mentioned that these fatty acids can compete for each other. If you give just DHA, you will drop your arachidonic acid level. So that's what I think we have to be careful. And we see that in the lab with some animal models. If you give just DHA, your arachidonic acid levels fall. Here, I show that with each fall of arachidonic acid, that being an important fatty acid for infants and the protection against infection, you have an increase in the risk of infection. So when we think about it, moving forward about finally perhaps tailoring a lipid emulsion that's more specific to the preterm infant's needs, think about those ratios and what we're providing. So putting it all together, current delivery of nutrition fails to maintain DHA levels. We can say maintain birth fatty acid levels in their ratios. We see for both arachidonic acid and DHA that decrease. They accrue this deficit, and I showed that these changes in fatty acids were associated with chronic lung disease and late onset sepsis. Need more numbers to really evaluate the possibility of NEC and other things that we see in the NICU. Also, what I'm going to come back to is this was purposely placed in our kids in this cohort. The average day that they were on full enteral feeds and off parenteral nutrition was about 14 days. So moving forward, strategies really need to think about both the parenteral phase of nutrition of our infants as well as the enteral phase. What if others have found? This recently came out as well, showing something very similar. But what was nice about this is that Lampione, you should read some of his articles if you haven't already. He has estimated what should be the accrual, the delivery of fatty acids to maintain those stores that they were otherwise supposed to receive. So using autopsy data and also content in skeletal muscle, the in utero accretion is thought to be about 45 mg per kilo per day. He looked at infants less than 28 weeks and about 40 infants. And he calculated, based on their feeding strategies, what they were delivering as far as mgs per kilo per day. So you see the same thing here. It's very low with this deficit, well below what otherwise would be the in utero accretion rate. So this is his demonstration of the data, week of life, and the cumulative DHA deficit, and how it progressively gets worse over time. And now this is related to both gestational age, but here he shows birth weight as well. So we're not doing a great job in maintaining polyunsaturated fatty acid levels in our babies after delivery and what they would otherwise be exposed to in utero. And I show that this may have implications for immunity and inflammation and the risk of disease. But does it make sense as it being, and again, it's not the entire story, but as one immunonutrient, does it make sense that that is part of a process that puts these babies at risk for multi-system diseases? So here's a schematic of some evidence about where polyunsaturated fatty acids have been shown to be important in the cellular processes. This happens to be, because my interest has been in the gut, an example in the epithelial cell, the intestinal cell, but you can really think of this as any cell in the body. These processes are very similar from organ to organ. So the first one here, the microbiome. How does PUFAs interact with the microbiome? That literature is just emerging, but it does appear that there's an influence on the adhesion of lactobacillus, and lactic acid bacteria dominate in that kind of nutritional environment. Not a bad thing. We talked about toll-like receptor signaling a little bit yesterday. An increased amount of toll-like receptor, especially TLR4, is thought to be in sort of the inflammatory and it triggers that it responds, and the interaction with the microbiome is thought to be one potential mechanism of necrotizing enterocolitis. PUFAs actually inhibit TLR4s, therefore it's signal transduction to the NF-kappa beta and the production of cytokines. I talked about the incorporation into cell membrane phospholipids. Fatty acids in of themselves are important regulators of resolvins, anti-inflammatory molecules, and inflammatory eicosanoids. You block, with appropriate membrane incorporation, you're able to produce resolvins and block the eicosanoid production. Finally, how may it will work with other transcriptional factors? It is known, DHA, to interact with PPARs. And then you have PPAR gamma here, which is an important negative modulator of the signal transduction of NF-kappa beta and cytokine production. But also, it's important in Paneth cell, or PPAR beta and delta, I guess that is important in Paneth cell differentiation. So we're back to that early intestinal cell differentiation, Paneth cells being important in the production of antimicrobial peptides and defensins. What about outside of my intestinal example? Well, if you look at PPAR gamma and where it's expressed and therefore potentially influenced by fatty acids and DHA, you see these markers in this in ileum, the small intestine, as well as in the lung. So DHA can have multi-system benefits, have mechanisms in place that are representative in more than one organ. Well, we've talked about this, prematurity being associated with low DHA. What happens when you provide the DHA? And we heard a little bit of this evidence. We have, and I'll briefly mention some of this, there have been NEC models that have looked at providing polyunsaturated fatty acids, also a mouse murine model of ROP, and then I'll briefly touch upon the preterm infant and what we know about that in the supplementation. So this is a study in the lab of Mickey Kaplan at Northwestern, where they looked at their necrotizing enterocolitis model and provided different ratios of these fatty acids. In their control, in their necrotizing enterocolitis model, they would get about a 50% incidence of necrotizing enterocolitis. You can see that with varying degrees of fatty acid supplementation, phospholipid supplementation, they get a reduction of that. DHA reduces that almost in half to 25%. In retinopathy of prematurity, this paper by Lois Smith at Children's Hospital in Boston, how she varied the fatty acid delivery was by actually giving it to the mom mouse. And it was through that, and then allowed them to dam feed, then that she was able to modulate or change the exposure of the pups and the fatty acids that they were receiving. Then the mouse pups would be exposed to elevated levels of oxygen, and they would then look at the retina, measure for vasobliteration and neovascularization. And they showed that these measures of retinopathy of prematurity were much less in the mothers who had received the omega-3 prominent diet. This is a transgenic mice that looks at FAT1, and that it's an interesting mutation, if I could display or relay it correctly, and that is that we can't go from an N6 to an N3 pathway. We just don't have the ability and the enzymes to do that. This is a mouse that they developed that actually can, which is great. So you can, and so it'll automatically shuttle any N6s to the N3 pathway. So it's a good model to look at the different ratios and balances. Anyway, you can see that in that mice, it also has decreased markers of the retinopathy of prematurity. So just a second way to look at the influence of omega-3s on retinopathy. So what about the preterm infant? Well, we heard just before this a couple of articles about that. When enterally supplemented, these are mean differences. So if you hit 0, it's not significant. That just hit 0. So the Bailey MDI at 18 months, generally supportive, but not completely statistically significant, and the motor outcomes, there were no difference. When they pulled all the results, their final conclusion that there was no clear long-term benefits or harm in the LC-PUFA supplementation. And we just saw this data as well, which was good, IPOKRaTES, in looking at the supplementation, and found the benefit among sort of the girls in this lower birth weight category. So why has the literature been somewhat mixed? And I'll highlight two things. One is we got to think about the timing. We got to give the, I think it was Dr. Hay who said you got to give the right thing at the right time. And if anything, I think that should be sort of the theme of this conference, these 3 days. We got to give the right thing at the right time. All the enteral supplementation strategies are coming too late. We have shown both now from this data and Lampion's data that those deficits are within the parenteral phase when the babies are predominantly receiving IV lipids, and it's happening pretty rapidly by a week. And even pouring in or giving supplementation later, you're not going to overcome this deficit. You might be already too late in the game to change that for the preterm infant. So the enteral strategies either need to be different, or that we can't rely solely on the enteral strategies to remedy this situation. The other thing, the second thing, again, it's a balance. It may not be just DHA again, so that alone, you may not see the benefits you want. You may want to see what you're doing with your other fatty acids. And that was just, we saw this yesterday, just to remind you, delayed enteral feedings. So enteral strategies aren't going to be probably your strongest signal in correcting this situation. The other thing is the maternal strategies and supplementation. All for it, I get it. Again, though, we separate them from mom, and they don't get a substantial amount of breast milk unless we dramatically change the way we're practicing right now. They're not getting a lot of that. So it's going to be good for later in their course. So if we go back here, definitely, things to accrue and consider during this enteral phase. But we're in a period here where we're in a 911. We got to figure out something now to be able to reduce this deficit. So people have started to look at this and looking at the actual lipid emulsions that we're receiving and that we're delivering. Again, the European investigators much more able to do this than we are right now in the United States, but a fair amount of groups are trying to change that. So this just came out. Fish oil fat emulsion supplementation may reduce the risk of severe retinopathy in very low birth weight infants. They looked at 40 infants, less than 1,250 grams. Their intervention was a combination or a blend of omegavin and intralipid. So we could talk about that, but omegavin is primarily a very heavy DHA, some EPA-rich solution. I'll just talk about it now because I don't talk about it a whole lot. We can talk about it more in Q&A, but it has shown to be beneficial in the reduction of PN-associated liver disease. Sure, it has its role there. We'll come back to that. So it's a DHA, EPA rich. Intralipid, I showed you already, is predominantly omega-6, or we discussed that already. These compositions can be blended together. So that's what these investigators were doing, is they were blending it together to see if they could get sort of the best of both worlds. They compared it to a historical control. So here's their experimental group. You can look at the demographics and the clinical, not much difference between the two groups, which is good. Did they see a change in much? Again, it's going to take large numbers. So I think this is a good feasibility pilot study. But to really look at sepsis, you're going to need much larger numbers than this. They didn't see that. IVH, they didn't see a difference. They saw a trend towards the cholestasis, so a la the previous literature by Mark Puder in the groups. But here, ROP requiring laser therapy, there's definitely a positive trend with less of the need for that in the experimental group compared to the historical group. So some indication that this actually might be helpful. What I haven't seen is I haven't seen a lot of levels being taken during these interventional studies. So I would like to see that going forward in the future. So back to the PN-associated liver disease. So this group said, well, we're not sure if it's just the omegavin, or is it the fact that when you're on this protocol for PN reduction of PN-associated liver disease, you drop your intralipid to 1 gram per kilo per day. Maybe it's the mere dropping of your intralipid actually what you're seeing as the beneficial effect, not so much the omegavin. Here again, wished the groups that have done the PN-associated liver disease would have taken levels as well, so we knew what was happening systemically to their fatty acid levels. And maybe they have that data, we just haven't seen it yet. So this group said, let's try that. Let's just drop them to 1 gram per kilo per day and see what happens. Well, when they did that, they saw a drop in their bilirubin level. This is the drop of the intralipid, and this is to continue on the same therapy. So there's a lot of things to consider about the utility of lipid emulsions, what you're doing with the dosing, and then again, an understanding of what you're providing. It may be, and then also this study in '93 just talked about, well, the intralipid, maybe there's some toxicity to it, and so looked at lipid hydroperoxides over the course and saw a tremendous signal in this free radical production. So maybe what you're seeing there with the reduction of intralipids is you're just reducing your linoleic acid. And in so doing that, you're reducing the precursor that goes down to arachidonic acid, which I showed could be protective of infection, but is also a very pro-inflammatory agent. So the understanding of what you're doing with each of these fatty acids and how they affect each other can inform your decision-making moving forward about what we should do with these changes. So to come back to my figure for these talks, so this is what we discussed yesterday, and then I discussed as one nutritional practice the PUFAs and long-chain fatty acids. Later this afternoon, we'll talk more about this pathway and those issues regarding systemic inflammatory response and systemic morbidity. And then another reminder of the immunonutrients. I wanted to add my email. I didn't yesterday, and apologize for that. I'm happy to have further offline discussions and sharing and anything else, and would love to hear about your practices as well. So thank you. So questions, yes.
Thank you very much. I would like to ask you the mother's nutrition during pregnancy and lactation concerning the high consumption of omega-6 and trans fatty acid and low intake of omega-3 has any effect on the fetus and the mother's milk? And one more question. Do you think there is any place for the addition of monounsaturated fatty acids in the emulsions for intravenous feeding, which helps to avoid the homeostasis?
Okay, so the first part, what do we know about maternal nutrition and fatty acids? Again, I think a lot of this is starting to emerge. There have been studies to show the diet being associated with the levels of the babies, the fatty acid levels of the baby. So there is, and as Dr. New had said earlier, a lot of our infant nutrition starts well before the pregnancy. So there is accruing evidence that, yes, in fact, that may play a role to the total amount of polyunsaturated fatty acids that you see. Having said that, we know there's a lot of variability in the data, and I must say when I did these crosscuts between 24, 5, 6, I didn't show you this on day 0, 31, 32, 33 weeks, remarkably consistent among almost 100 women and what these birth levels were. So I think two things. One is, yes, I do think it can be modifiable in the maternal nutrition, but two, these mechanisms are in place that it really optimizes that environment, that nutritional environment for the development of the baby. As well as, and then just to follow through or be more complete with the answer is, we have been seeing much variability, and there's been studies about that of recent too, of course, of fatty acid levels in breast milk, and that's why there's still a room and an opportunity to even supplement breast milk, and that has been shown to be important in the content that's been delivering to the babies, and some benefit in that enteral phase, even though started late. The monounsaturated for the you had said for the importance of what? Can you repeat that last question? Oh, the prevention of cholestasis. I actually don't know much about that, to be honest with you. Do you, Joe?
There's one study that's been done in Australia that I'm familiar with, where they added olive oil preparation to monounsaturated oleic acid to the intravenous lipid formulation, and they did not see a change in cholestasis, but they did see, using tracer studies, an increase in the very long chain, the PUFA, very long chain PUFA synthesis, endogenous synthesis. So you can actually get a greater synthesis of your very long chain DHAs using that formulation. So indirectly, it may be helping.
Thank you. Yes.
Thank you for your stimulating lecture. From the practical point of view, what would be your suggestion in modifying the intralipid intake in babies with infection, and especially babies with candida infection? Should we modify or continue to give 3 grams per kilo per day?
No, I think that's a great question, and the same question comes up with the pulmonary morbidities, and you'll see recommendations for both that, perhaps you should drop down your total lipids from 3.5, to maybe 1. I just, right now, you're sort of caught between a rock and a hard place. Right now, I think the fat delivery, the energy source, the alternate fuel source, being able to kind of move away from just solely carbohydrates, we'll talk about that a little bit in surgical conditions, that I don't modify my total intralipid delivery during those states, because I'm trying to balance sort of that risk, but also the risk of not providing enough. But even the more reason to let's get away from a product that was essentially an adult product that hasn't changed in 25, 30, 40 years, and let's start thinking about how we can tailor it to the premature needs. But I don't change. I don't know if others drop down their intralipid emulsions, but I do not. Yes.
Per kilo per day and not higher?
Why? What? Say that again.
Omega-1, the fish oil in the TPN.
I don't know. In talking just personal conversations with Mark Puder, I don't think they know. I think they just started somewhere. I really don't think there was a sort of enough pre-existing knowledge to guide that dose. And so I think they were just starting at that, and I think they were starting at a level 2 that they wanted to prevent any sort of, again, we know that that's the minimal intake amount that you can prevent some essential fatty acid deficiency, and they have published that even with the DHA-rich and the omega-vin, they can prevent sort of that essential development of the essential fatty acid delivery. But I don't think there was any more scientific basis about trying to calculate how much DHA you were providing and what that would equate to as in a dose. Yes.
You said that low birth weight and low gestational age babies have a higher triglyceride level. Is it because the liver does not function well, or why, actually?
Yeah, I don't know. I don't know why they're more at risk for elevated, whether it's developmental. I mean, it seems like it would be developmental, but what's specific about that developmental? What is it, the carnitine transports? Is it other functions within the liver? I don't think we know.
Mm-hmm. And do you know whether mothers who have preeclampsia or any disorder during pregnancy have a lower DHA, and what should they be fed in order to produce more DHA?
So there's one study I recall where they looked at the cord fatty acid levels in babies who were growth restricted, and those were lower. That's why actually I controlled for it in this model. And I think there was only one, and those fatty acid levels were lower in the growth-restricted babies compared to babies that were appropriate for gestational age. So there does, most growth restriction in this study were as a result of preeclampsia. So there does seem to be some effect on polyunsaturated fatty acid delivery and what the baby sees.
And what the mother has to eat?
Whether or not that will translate to higher levels or there was more downstream regulatory effects that were preventing the transfer, you know what I mean? Whether just providing more substrate was enough to overcome perhaps whatever placental abnormalities were causing the preeclampsia, we don't know that, and the study has not been done yet to see if supplementation alone would overcome that. Yeah. All right, thank you very much.